Today we will discuss the procedure of cerebrospinal fluid cell events. Principle: cerebrospinal fluids are manually counted in a hemocytometer chamber to get a WBC or nucleated cell count and also RBC count. A slide is made after centrifugation and stained. The stained slide is examined and 100 cells are counted and differentiated into cell types. Clinical significance: aids in the detection of and diagnosis of organic central nervous system disease. An elevated leukocyte count usually indicates meningeal irritation, either aseptic or septic. The cellular reaction, neutrophilic, lymphocytic, or mixed, depends upon the nature and the duration of the disease, that is meningitis, meningoencephalitis. Presence of RBCs in CSF are indicative of subdural bleeds or bloody tap. Specimens: patient preparation, type of specimen CSF, amount of specimen at least 500 microliters of fluid is necessary for the whole procedure. Collection requirements and handling: an epic order will print out for each fluid sent to the lab. Specimen is collected via lumbar puncture by the physician. A special kit containing 4 sterile tubes is used. Card must be taken to fill the tubes in the order in which they are marked. Tube should be labeled with patient name, date, and time of collection. Cell counts should be performed within 1 hour of the collection to lessen the chance of cellular degradation. All other testings should be performed as soon as possible and culture set up before specimen is refrigerated. And the remaining sample can be refrigerated at 2 to 8 degrees centigrade or frozen for long-term storage. Specimen tubes will be processed. Tube 1. It is not used for routine testing. Useful comparison of color or turbidity if a traumatic tap is suspected. And tube 2 used for chemistry and microbiological testing. Tube 3 used for the cell count and for visual observation for color and turbidity. Transfer a small amount of the fluid to an EDTA tube and gently mix. This will be used to perform the cell count. And the tube 4 saved for reference testing if requested. Frozen if additional testing is not requested. Stability: all specimens should have the cell count finished and entered within an hour because of the cell lysis. All fluids are kept for 1 week. Criteria for unacceptable specimens: samples with clots will be attempted, but a comment "clot present, cell count may be inaccurate" should be attached to the test results. Leaked vials should be indicated on comment field as vials leaked, results questionable. Samples with excess oil, powder, or completely clotted may be rejected and test cancelled. Fluids with clusters of WBCs present should have a comment added as "cluster of WBCs present, count may be inaccurate." Precautions: CSF should be handled according to the universal precautions and the blood-borne pathogen standards. Reagents or materials required: analytical methods for glucose protein on CSF, in situ C-chip disposable hemocytometer, body fluid cell count controls, normal saline, microscope, glass slide, stain for the differential count, and agars, blood or chocolate or McConkey agar, depending upon the requirement, and micro incubator or candle jar. Quality assurance is monitored by proficiency testing services. 1 level of commercial control will be tested in duplicate with the first cell count of the day and every 8 hours thereafter in the event of additional cell count. Records results on log sheet. Record on specimen, CSF or fluid, manual cell count, worksheet. Picard Appearance: normal CSF is crystal clear with a viscosity similar to water. Abnormal CSF may appear hazy, cloudy, or turbid and range in a color from slightly tinged with yellow or grossly bloody. Turbidity: using tube 3, grade as clear, hazy, cloudy, or turbid. Color should be judged on a centrifuged sample and the supernatant described as colorless or whatever shade of color is noted. The tube should be centrifuged within an hour of the collection or a false xanthochroid may occur. Presence of clots or mucilaginous material should be noted. Charge the hemocytometer with well-mixed specimen. Put specimen into the sampling area so that it fills by capillary action. Be careful not to introduce bubbles into the counting chamber. Counts both WBC and RBCs in all the 9 squares on both sides. RBCs have distinct outlines with halos and clear center. If crenated, they have many fine pointed projections. WBCs will be granular. Tissue cells are usually large granular cells with irregular outline. These cells should be included in the nucleated cell count. These cells will be sorted out in a differential count. If clumps or clusters of cells are present, comment as clumps of cells present, count may be falsely decreased. Average the count on both sides. Count should be within 10%. Add 10% for the total count per mm cube. If specimen is visibly bloody or turbid, make a dilution using normal saline. Make sure to adjust for your dilution factor when calculating. WBC is differential. If manual WBC count is less than 100, specimen should be sent to lab for a cytosine differential. And if WBC count is more than 100, centrifuge the CSF for 5 minutes. Save the supernatant. Label the slide with liquid label. Suspend the sediment and pipette a drop to a clean glass slide, dry and stain as per a regular differential. Perform 100 cell differential on any spinal fluid with WBC, distinguishing the neutrophils, lymphocytes, monocytes, eosinophils, basophils, and large mononuclear cells, mesothelial cells, macrophages, or histiocytes, blasts, plasma cells, and other malignant appearing cells. When any large mononuclear cells are reported, a pathological review order will be generated. Fill out a path review form and send to the lab for review. RBCs and polymorphic nucleated WBCs are not present in a normal cerebrospinal fluid. Their presence can be attributed to a traumatic tap. Total WBC count of less than 8, comprised of all lymphocytes, can be considered a normal finding. An increased number of WBCs with mainly lymphocytes indicates possibly aseptic meningitis, encephalitis. An increased number of WBCs with mainly polymorphs indicates possible bacterial meningitis. CSF differential slides will be saved for a minimum of 2 weeks. Slides sent for pathology review will be saved for 25 years by the pathological department in few institutions. Limitations. Interfering substances, talcum, glove powder, and other artifacts may affect the count, and specimens contaminated with them are not acceptable specimens. The most commonly performed chemistry tests on CSF are protein and glucose. Chloride may also be requested. Follow analyzer-specific procedures for performing the chemistry test, and appropriate controls must be utilized. Normal values of a CSF are protein 15 to 45 mg per deciliter and glucose 45 to 75 mg per deciliter. Culture and gram stain. The culture is set up on the centrifuged sediment of tube 2 after any chemistries have been performed. Tube 1 may also be used. If the sample is very cloudy or bloody, it may be necessary to perform the gram stain on centrifuged fluid. See the CSF culture procedure in the microbiology manual. The gram stain results should be reported along with the cell counts and chemistry tests as soon as possible. Resulting cell counts, chemistries, and cultures for CSF should also be ordered separately through a pick or beaker and resulted accordingly. In the event of EPIC or beaker downtime, that results, that is cell count, differential chemistries, and gram stains, will be manually relayed to the provider as soon as they are completed. Results will be entered into the system when connection is restored. Reviews and changes. This document and all attached forms should be reviewed optimally on an annual basis, with 2 years as the maximum review. Review will be done by a technical leader, supervisor, manager, medical director, or designated person. Changes require retyping the document or form and review by a medical director.